everyone, and a very warm welcome to you all. I'm Neetu Abraham, Community Manager at MediSage eLearning, a platform made by the doctors for the doctors, created to foster continuous knowledge sharing, meaningful learning, and professional collaboration. On behalf of MediSage, I'm delighted to welcome you all to Sexual Health Pathshala to SexMed Connect, where today we will be discussing on the topic couple therapy. With this, now I would like to hand over the session to Dr. Shama Sultana. Over to you, ma'am.
Yes, good evening. Welcome to SexMed Connect, Sexual Health Ki Pathshala, Sexual Health Forum for OBS-GYN. It is a pure academic forum for gynecologists to learn, discuss, and share knowledge on sexual health topics. By joining SexMed Connect, you can also enhance patient care, as well as we have a network and collaboration and stay informed about the sexual health topics. We have a WhatsApp group where we have an academic WhatsApp group for discussion and learning about sexual health problems as well, and we have Instagram, YouTube channel, and also Facebook, where we have updates about the academic information, videos, and posts on sexual health. And today's topic, that is couple therapy, this is actually a topic which is very near to our hearts, but we don't discuss much. Sexual health is an important and often overlooked aspect of overall well-being. And many couples experience challenges related to intimacy, communication, and also sexual satisfaction, but often hesitate to seek help due to stigma or lack of awareness. Through this webinar, we aim to highlight the importance of couple-centered approaches in sexual health care, where both partners are involved in understanding, supporting, and addressing concerns together. So thanks for joining, and also I want to invite our co-moderator, Dr. Richa Paharia ma'am, to take over the session and invite our speaker of today.
Richa, you are muted. Unmute.
Good evening, everyone. A very warm welcome to you all. Today is a very special day, as in our Sexual Health Ki Pathshala, we have a very important person who will be talking to us about a very different kind of a topic, that is couple therapy, which is so very important in sexual health. And our very experienced Dr. Sunita Menon will be taking up the session. And a few lines about her. Madam is a very well-known person. She has done her master's from Swinburne University of Technology, Australia, in professional counseling, specialized in CBT, and a certified sex therapist from the Buller Institute, USA. In private practice in Chennai, Madam has covered over 10,000 hours of counseling. That's a great achievement, and she sees both individuals and couples. Madam is a LGBTQI plus affirmative therapist. And so we have the session to you, Madam. Over to you, and Madam will be taking up the session now.
Thank you, Richa. Thank you. And thank you, Shama, too. Okay, now I have to share, right?
Yes, ma'am.
Okay. Is that okay?
Ma'am, actually, probably you have make it zoom, like you increase the size of the letter. That's why make it normal, ma'am.
It's very zoom out.
So how do I zoom out?
Slideshow. Share and do
I think
slideshow.
So how do I zoom out of this?
again, ma'am, do share screen share, please.
Oopsie. So hang on. Oh boy. And then see, now I can't find it. Oh, I'm so sorry. I'm so sorry.
Once open the PowerPoint in your laptop, ma'am.
I'm on my desktop. So yeah, I have it here. And then so how do I get
Come to
it?
the
Alama.
come to the Zoom meeting and share, ma'am. Share.
So share, but I don't have the PowerPoint here.
You just minimize this zoom and just open in background first.
Okay. So I minimize. I'm truly sorry, huh?
Okay, ma'am.
Ma'am, if you can share your entire screen, I can guide you how to reduce the
How
size.
to reduce what?
The size of your screen.
Okay, so here you are, and then how do I share with
So
you?
when you click on share now, there is an option called entire screen. Just click
Neetu,
on
can you
and then
pause the video? We will set and again start.
Okay, wait, hang on. So you first want me to pause?
No, no, not you, ma'am.
No, what do you want me to do? Who? I'm
Ma'am,
really.
you
should I
share.
stop pause? Should I pause, ma'am?
Neetu,
Record.
Madam, you stop sharing and you
yes, yes.
share.
Okay, done. Thank you.
Yeah. You can start, ma'am.
Okay. I'm so sorry. First, my apologies. As I was just telling them earlier, I'm technologically challenged. Forgive me. First and foremost, I needed to thank the team, Dr. Neeraj and his team, for choosing this very important and very sensitive topic in couples counseling. Um, I want to also say when in our jargon as a therapist, when we say couples, we don't mean only heterosexual couples. Yes, we mean we can have same-sex couples also. We can have couples in marriage. We can have couples who are not married also. So there's a wide spectrum. And so this entire presentation of mine is just in order to familiarize you all with what are the dynamics we find today in modern day relationships and how it tends to influence and impact sexual wellness. So this is what the talk is going to be about. Okay, so I'm going to give a disclaimer here. My intent in this presentation is not to change the way you think, because all of us come with a lot of baggage, and this baggage we carry to our clinic comes from the kind of exposure we have had, the kind of life experiences we've had, our levels of education, the culture, religion, socioeconomic strata. There are so many factors that come into play in order to influence how we think and what we believe about relationships. So it's not my job here to change the way you think, but it definitely is my purpose to arouse in you an element of curiosity that will make you want to know more and perhaps lead you to explore what modern day relationship dynamics look like and the kind of impact it can have on your patients. So I want for you to, I'm going to give you a huge number here, and I want you to do a little bit of thinking about it before we even start. You needed to remind yourself that 1 in 10 of your patients is in a non-monogamous relationship. And they have simply not told you this because you have simply not cared to ask. So we go by the rule, you don't ask, I don't tell, or I don't tell, you don't ask, whichever way. So the onus is on you. When your patient walks into your room, you have to take charge here, and you have to, in a very sensitive way, ask them about the nature of the relationship. You cannot make assumptions or speculate. Most of us tend to do that. I want for you all to constantly remind yourself, hey, 1 in 10 are in a non-monogamous relationship. I cannot assume, I must ask. And of course, there is a slide on how you can ask this also. We will get to that. So what are you likely to be thinking every time a patient walks into your room? You're going to be thinking that, hey, my patient, she looks married, because we are a Guyanese, I'm going to say this. Oh, she looks married. She looks like she's in a heterosexual relationship, so I can just assume. Or you're going to think that, well, who wants to get into relationship dynamics? It doesn't concern me. I'm here just to attend to the body, and I'm going to begin with that and end with that. Or you're going to be thinking that I got loads of patients waiting outside. I don't have the time to indulge in asking about their relationship dynamics. And so I'm just in my 10-minute consult, all of this doesn't concern me. I'm just going to stick to the body and the presenting issue. You might also ask, how is this relevant to me as a gynec? So I'm here to show you that your patients, whether you like it or not, are living a life where 1 in 10 of them is non-monogamous. And they are simply not speaking about it. They are simply not disclosing it to you because they have no idea how you might react or respond to their disclosure. Plus, they take comfort in the fact, some of them, that you haven't asked. So there is no need for me to disclose. What you tend to then forget is knowing about their relationship dynamics will be for you the most important part in the puzzle, or the most important part that will contribute towards you making a diagnostic formulation of your client's presenting issue. It will hardly take you 10 seconds to ask a question. And trust me on this, the moment you ask the question, they're just going to open up. This I can tell you from my experience. I have said it before also, that to date, there hasn't been a single client of mine who has not answered honestly to me about the nature of their relationship. They are just waiting to be asked. They might give you just enough information, and then it's up to you. Once you get your foot into the door, then it's for you to ask more if you believe that it is relevant to their presenting issue. Okay, so some of the lines you can use, I just put a couple here, 3 of them here. You can use this. This is a good place to start from. One of which is, can you tell me about your relationship setup at the moment? So which means you are passing on the information to your client that, hey, I'm not going to assume, feel free to tell me what the nature of your relationship is. That already then puts your patient at comfort, because, hey, my doc is not making an assumption and he or she is open enough to ask me about the setup. Another one could be is, in order to make them comfortable and not feel like you're just zeroing in on them alone, where you say that this is something I ask everyone, not just you. Are you happy with your current sexual health? So it kind of, it normalizes the question, not just you, but I ask this of every patient of mine. And the third one would be that, where you can say that some people find that relationship stress shows up physically. Does that resonate? Now, I think this is a very important opening line, because when a client presents a symptom to you, it is important for you to also check in as to what the story behind that symptom is. There usually is a story. And so if you were to say that, some people find that relationships shows up somatically, physically, do you think that's true? And if so, you want to help me with this one. So I gave you some examples here on how you can start the conversation with them. So with my presentation, what do I intend to, what are the objectives? One of which is, I would like for you to get an overall, it's like a tip of the iceberg, but I would like for you to understand a little bit about modern relationship structures and why patients are so reluctant to disclose them. But the moment you ask, they just open up. I would like also for you to take away from this presentation that the context of their relationship plays a significant role in the clinical presentation of your patient. I would also like for you to take away from this that it is important for you, besides the bio, to also factor the psychosocial context your client comes from and the complaints that they present to you in your clinic. Since you are frontliners doctors, I would also like for you to take away from this presentation that it is your responsibility to keep an eye out for any signs of trauma and safeguarding indicators within your client's sexual health context. It is your responsibility to pick up on any cues, verbal, non-verbal, that your patient is giving you about trauma. I would also like for you to deal with your LGBTQI plus patients with greater confidence. From my experience, I find that usually doctors they lack confidence when they deal with LGBTQI patients. It's not that they have a stigma or they have a judgment, a moral judgment about it. It's simply because they lack the confidence in dealing with them. So I'm hoping that this presentation, I have a slide or 2 on them. I hope that will also give you a little bit of an insight, which will make you curious, of course, and then want to explore on how to deal with them in a more confident way. And of course, the last expectation I have of this presentation is for you to know when you need to refer your patient to a therapist, either a sex therapist or a CBT therapist, in order to be able to deal with what is between their ears. So let's begin with the first bit. The first bit is, what are modern relationship structures like? As I said in the very beginning, I'm going to be talking, when I say couples, and when we talk about couples counseling, we deal with both monogamous and non-monogamous relationships. So what are monogamous relationships? Monogamous relationships are when one person is in an romantic / intimate relationship with another person. So monogamous is one person with another person. It could be heterosexual. It can be same sex or it can be the opposite sex. So this is monogamy, which is most likely what you all are seeing, but there is a lot more that you're not seeing. And it's that bit that I today want to focus on. So let's delve into what is non-monogamy. So, as I said, the first statistic I gave you was that 1 in 10 of your patients is in a non-monogamous relationship. The second bit is 9% of adults practice consensual non-monogamy. I will explain what consensual non-monogamy is. And the third one is almost all of them will not speak about it until and unless you ask. So what is non-monogamy? So again, non-monogamous relationships are again two. One is ethical, or what we say consensual non-monogamy, and the other one is what in common parlance we say cheating. So consensual non-monogamy means that the two people in the primary relationship have the consent of each other and are honest with each other about romantic or intimate partners that they have outside of the primary relationship. So that is what consensual ethical non-monogamy means. The two important words are, do I have the consent, and am I honest enough with my primary partner about my relationship outside of this primary relationship? So we call it ethical non-monogamy. You'd be surprised how many of your patients are practicing this. So what are the different kinds of, I just put a few here. There are many, many more labels that you can give for the different kinds of ethical non-monogamy that our patients practice. One, of course, is polyamory, which is becoming more and more common now. Polyamory would mean that one person who is in the primary relationship or both people in the primary relationship can also be sexually and romantically involved with other people outside of the primary relationship, sometimes more than one or more than two. There could be many people, and there is not only the body that is involved, but also the heart. So which means they can also be in love with more than one person. So ethical non-monogamy and polyamory, we find that a polyamorous couple, both of them have multiple partners who they are in love with and who they are intimate with outside of the primary relationship. Another one would be an open relationship. Again, a primary couple here, but both of which are honest with each other and have the consent of one another to have an intimate relationship outside of this primary relationship. So that's an open relationship. Then you have a situationship, that you could have a couple who really haven't labeled their relationship and they kind of are committed to each other. So because there's no label or no name given to it, but they are with each other, we call it a situationship. It could present in the clinic or with your client or your patient. Sorry, I keep using the word client because that's how we refer to who you call patients. Yes, so please forgive me for that. So your patient who is in a situationship perhaps could show anxiety or distress because they are in a relationship that has not been labeled or defined as yet, and that could be causing them stress. Then we also have, this is again is very new, very popular in Japan, and I'm told catching up everywhere else now, is about living apart together. We have couples who are in a monogamous relationship, but live apart, live away from each other by choice with the consent of each other. This is by choice, essentially by choice, that they don't live together and they could be in a non-monogamous relationship. But the key words, as I told you, are consent and honesty. Now, the last bit, this is something for you to watch out for because, as I told you earlier, you guys are frontline, right? Now, we have also what is called in ethical non-monogamy, we have what is also called coercive open. So, which means technically, by definition, we have the consent and we are honest with each other to have romantic sexual partners outside of the relationship. But you might sometimes come across a patient who is not completely on board, was compelled to, was coerced to get into this arrangement with their partner. So you need to watch out for that because this also can show up with some symptoms. We will get into that a little further. I know this is a lot for you, but there are many more terms. But what we need to understand here is that relationship dynamics have changed and you must acknowledge it and you must accept it, being non-judgmental about it. I mean, look around. I know most of us have grown up made to believe that a monogamous relationship or a marriage is the ideal. But it's about time we challenge ourselves, we become curious, and we look around us and ask ourselves, is there any evidence to prove that marriage is ideal or monogamy is ideal? Because if we have certain myths or preconceived notions in our head, we definitely, as a CBT therapist, I'm going to tell you this, we are only going to look for evidence to support our myths in our head. But as doctors, I think you'll need to start challenging yourself. There is no right way or the way. There are many ways. Now I move to the next slide. So the clinical cost of you not asking about the structure of their relationship might end up with you working with an incomplete formulation. Please remember that. And if you do not ask about the structure of their relationship, then you might be missing the story behind the symptoms. Every symptom has a story. So please, please, please ask about the structure of the relationship. Okay. So I'm not going to go into detail in this slide, just some complaints that patients might present to you when they are in a situationship, things like insomnia or generalized anxiety disorder, or if it's polyamory, especially, this is something, I'm going to speak about this one. So now polyamory is becoming quite fashionable in India. So I'm beginning to find that I'm seeing a much more than before couples who claim to be in a polyamorous relationship. And I find that when they are in a polyamorous relationship for the first time, and so what we call a new polyamorous relationship, they do tend to experience things like anxiety, jealousy, all of that shows up. But the moment they become veterans at being polyamorous, all of these disappear. So couples who are newly polyamorous, who have come out and labeled themselves polyamorous, we find tend to have some symptoms of comparison anxiety and somatic. Yeah. The one I'm going to, which is in red, is coercive open, because I told you, remember, you are frontline. This is something you must watch out for. If, for instance, you find that your patient is depressed or comes with chronic pelvic pain or is avoiding having sex, then it's nice for you to ask about the structure of the relationship. Yeah, for instance, it could be a coercive open relationship, and so she's simply scared to be having sex with her husband. Okay, so hang on. So a little bit of psych education before I step into this slide in detail. I know y'all are not into therapy, y'all are not psychologists, but I'm just going to give you a little bit about attachment theory. So Bowlby came up with attachment theory, but of course, when he came up with the theory, it was more about the attachment of an infant to the primary caregiver, in this case, mother. So the experiment he did, and which was done following him also, essentially says that infants can have two kinds of attachments. One is a very secure attachment with the primary caregiver. In his case, in his experiment, it was the mother. And infants can also have a very insecure attachment style. So, for instance, a secure attachment style an infant can have with the mother is the mother and the child can be in the room, and the mother will be doing her own thing, and the infant can be doing its own thing. And when the mother steps out of the room, the infant will see the mother go out of the room, but the infant is not anxious because the infant is secure enough to know that the mother will come back. And when the mother does come back, the infant will run to the mother, will want some display of affection, and then after which the infant goes about doing its own stuff yet again. This is a secure attachment style. So what you're going to most likely to be seeing in your clinic are patients with an insecure attachment style. So how does that show up? What is insecure attachment style? Again, continuing with infant and mother, we can have two kinds of insecure attachments. One is a very anxious attachment style, and the other one is a very avoidant attachment style. So I'm going to move to adults here. Women, let us talk about women because as gynecologists, you all see mostly women. So a patient of yours who shows an anxious attachment style would show signs of, every time the husband goes away, the husband or wife is scared whether she will be abandoned. And so she waits anxiously for the husband to come back. And when he comes back, she will want to be made to feel secure, and then she might cling on to the husband for a little while because she's scared he's again going to leave her. So this is anxious attachment. Always wary of when the husband is or whoever they're in a relationship with. In case of same sex, another woman, if they are anxiously attached to them, they will always be wary of when this person is going to exit and when this person is going to come back, and when this person comes back, will this person be the same as they were before. So this is anxious attachment. As for avoidant attachment, continuing with mother and infant, when the infant sees the mother go out of the room, the infant doesn't really care. The mother comes back into the room, the infant sees the mother come back, but the infant doesn't really care. And then the infant just goes about doing its own stuff. So whether the mother is there, not there, the infant is well aware, but no big deal. So this is called avoidant attachment style. You might present in your clinic with a woman who, okay, I don't care if he's there, not there, or if it's a same-sex couple, if she's there, if she's not there, I just go about my life. So you could see this presenting in your clinic. I'm not asking for you to find out, hey, is this an anxious attachment style or an avoidant attachment style? But it's nice for you to know if your patient has an attachment style that is insecure, because that is an important part of you understanding the relationship dynamics of your patient. And of course, I have given here, I will be passing on this presentation to Dr. Neeraj, so you have everything here. So what are some of the typical symptoms you could find with patients who have anxious attachment and avoidant attachment? I'm not going to go into them. Even when he shares the slide, you have the necessary details there. Okay, so what's the important thing? As I said, I don't expect for you all to be able to assess what their attachment style is, but I definitely want for you to be aware of what it looks like, because especially if you have a patient who has a very anxious attachment style, you could find that it might lead to a crisis. So better for you to catch it early, and then, as I've said, refer them to a therapist or a psychologist who you feel could help them deal with their insecure attachment style. But this is important because it impacts the dynamics between a couple, whether same sex or opposite sex. Why doesn't it go to the next screen?
Maybe just your network issue. Just wait few seconds, it will move. Neetu? Neetu?
Neetu has disappeared too.
Wait.
It doesn't seem to move.
1 meter. She is there. Neetu? Hello, Neetu?
Hello.
Yeah,
Neetu?
Neetu, please correct.
Sir, it went off in between because of my net issue. Is it okay now?
No, I'm
Wait,
not
wait.
able to move to the next slide.
You are not able to go to next slide.
Yeah.
Ma'am, just press escape button.
Oh no, not.
Escape from your keyboard. Keyboard, there is
I
escape.
have pressed escape. It doesn't seem to.
Just a second.
Yeah.
Ma'am, just
Now
stop
it's
sharing your
Okay, so
screen.
we got it back. Okay,
Okay.
thank you. Done. So we'll move to the next thing. So the next thing you needed to know about relationship dynamics in couples counseling when your when your patient comes in is for you to also factor in that your patients could be impacted by technology. Yes, one is the dating game, and the other one is, of course, pornography and social media. So, for you to understand the dynamics between a couple or with your patient and the kind of relationships she has, I would like very much for you to factor in pornography. So, couples or even individuals, when we say pornography, we don't see pornography as an evil. The first thing we check is whether pornography, the usage is normative or is it problematic. An example of normative use of pornography would be a patient uses ethical pornography, which means it's a paid for site and it's not something that is free, because that's an industry you don't want to encourage unless it is paid for. Normative use of pornography example would be a couple tends to use pornography in order as a part of foreplay. Normative again. So what is problematic? Problematic is if you find that your client needs pornography to be able to have an orgasm or needs to have pornography to even indulge in partnered sex. All of this would be problematic, or if they show signs of addiction. So first and foremost, it's important that you differentiate between normative and problematic use of pornography. I would like very much for you to also get, when you are speaking with your patient, to understand in the relationship whether technology plays a role. It could be the third person also sometimes in the relationship. When we say technology, pornography is one of them. The other one is dating apps. Not every woman who comes to you is in a committed relationship or in a partnered relationship with another same sex or opposite sex. They could also be on a dating app and going on dates and having hookups, as they call it. Remember this, with dating apps, what has now happened is there is a rapid turnaround. So you can have multiple sexual partners, and they're a couple at that point. They're also a couple, right? But it's multiple. You can be in a partnership with someone, in a relationship with someone, and then overnight you could dump them and move on. So there is this increased frequency, yes, and sometimes even increased rejection frequency. So I want for you to also check in about when a woman comes in, whether what her relationship structure is, and whether she relies on dating apps and the frequency and all of that. So that's something again with technology, besides pornography, checking in about dating apps. And of course, the third one is social media. Social media, because of social media, there's a lot of comparison happening, and that too could perhaps influence the dynamics between the couple. So it's important you also maybe delve into it if you believe there is a need for it. So the role of technology also plays a significant technology plays a significant role in the dynamics between two people in a relationship. So you must factor that in. And the three aspects of technology that I have put here are dating apps, pornography, and social media. Okay, all the patients you see are not over the age of 18 or 21. There are many girls who also come to you, and so I thought I must dedicate one slide to adolescents. Adolescents can also be in a relationship. So it's important for you to understand the nature of relationships that adolescents tend to have. So, especially if they are under the age of 16, one is illegal. And they also tend to deal very differently from an adult as far as rejection goes. I'm sure most of us have seen the web series, right? Adolescents. So I thought I would just put in a slide here for you to acknowledge the fact that you will have patients under the age of 18, under the age of 16, who are in relationships and who are sexually active. So please also understand this, because unlike adults, they will not be able to tell you why they are triggered. And so it's for you to be patient, be nurturing, and be curious and non-judgmental, and try to understand their triggers. Some of them you might find have normalized what we call coercive sexting. A lot of under 16 and under 18 indulge in sexting. It's okay as long as it's not coercive. So you need to check in. Are they feeling compelled to sext? Shared nude photographs and all of that. This is something, again, you have to check whether their relationship with another person involves them being coerced to sext. Again, when you get a young client who's an adolescent under the age of 16 or 18, it would be important for you to understand whether they use pornography as their source of all information regarding sex. And the last one, again, I've highlighted that because I think that's the most important factor. You, as I said, your adolescent clients who are in sexual relationships, you want to call them a couple, so be it, but you need to factor in this bit. If they are in a relationship with people who are adults, yes, whether it's the same sex or opposite sex, whether their sexual partner is an adult and they are under the age of 18, then please, especially if the man or the woman is much older to them, and if you sense here that, you know, there are things like unexplained gifts or a kind of lifestyle that doesn't really suit the socioeconomic strata that the adolescent comes from, then all of these are red flags for you to little bit deep dive into, so that you understand the dynamics of the relationship they are in, and what the nature of the problem that they are presenting is. This is going to help you. So that's why I highlighted it. Because you might find that being frontline, that especially in an adolescent's case, the parents are going to be the last people to know, and you might be the first person to know. So don't miss this opportunity for you to learn something more that could result in them being safe. Yes. So talking about safety, I thought I should also mention not all relationships, not all couples are in safe relationships. So this is something as frontline you also need to keep an eye out for. Please remind your patients who are in relationships that if you said yes once, it doesn't imply that it is a yes always. Yes, a yes can be withdrawn at any time. And it, for every context, it can be a yes or a no. And that's for you to remind your patient if they are in a relationship. The next thing that you're likely to see with couples is about reproductive coercion. You might come across women in your practice who feel that they are being coerced into bearing children. So this is something, again, for you to watch out for, because this again comes under couples counseling. Digital coercion, I have spoken about a little earlier about sexting and all of that, but I just dropped it here so that you're aware of it, that adults too can be digitally coerced in their relationship. Like for instance, a husband might be traveling, or a wife might be traveling, and they might be missing each other and missing not having sex, and they might ask for them to the other to send them nude photographs and all of that, and one person in that relationship might not want to but feel coerced to. What if I don't? Then will the other person go elsewhere seeking sex? Or you'll be surprised by the way the brain works. So keep an eye out for this also, because you're looking at the dynamics between the couple, yeah, whether there is digital coercion in that adult relationship. About CBT, I will say this, that CBT, you all deal with the body, right? But as cognitive behavioral therapists, for us, we deal with the way the client, your patient thinks, the way your client behaves, your patient behaves, and the way your patient feels. So for us, it involves their thinking, feeling, and behavior. So CBT formulation is important when they come in, and as I told you earlier, it's not just the symptoms that you must address, but you must also try to find out what is the story behind their symptoms, especially with couples. Okay, this is the biopsychosocial lens. Just a brief note here. I know you all will be most inclined to go towards the biological, but I'm going to request for you all, if you want to understand the dynamics between the couple, then you also need to check in about the social strata that they come from, the culture, the relationship, the relationship structure, the dynamics between them, and whether there is any stigma or shame that you sense in their relationship. Catch that. That's the social component. The psychological component of your patient would imply, what is their mood like? Do they have body image issues, or do they have performance anxiety in bed, or whether they have any past trauma as far as sex goes or physical abuse goes. All of these psychological and social components also will impact the relationship between a couple. And for you as a medical doctor, you need to also, besides the biological, look into the psychological and social. Okay, one example I have given here, for instance, if you have a 35-year-old who comes in with low libido, and the blood works are all normal, and then the GP, of course not you, the GP will prescribe testosterone gel, and then no improvement, and then referred it to you, and then you're going to do whatever it takes to understand the case better. All I'm asking, if in the in the biopsychosocial framework or lens, I'm asking for you to also delve into what is the relationship structure, whether they have performance anxiety, or what are the religious or cultural taboos that they live with, whether there is any past trauma, and all of that. All of this will come under the psychosocial framework. And use the CBT bit where you talk about, you delve into how are they thinking, how are they feeling, and how are they behaving. The three things. Yeah. So now couples. Now this is a big issue because in my practice, I'm going to talk about in my practice, I see a lot of clients who are also in non-monogamous relationships that are not consensual. So which means there is no honesty and there is no permission from the other person in the primary relationship. So when we ask for them, when all hell has broken loose, then the first thing as a therapist we do is we say that, hey, both of you need to go to a doctor and get yourself tested before we go any further, because the ramifications, if anything comes out positive, are far more than, just us talking is going to help. So, so when we ask for them to go, I find that most of them know that they must go. They all across the board will admit how important it is to go to a doctor and get tested for it. But there are so many barriers to them moving. They know it, but for them to get to overcome the psychological barrier to visit one of you and get tested is horrendous. You struggle. It takes you sometimes weeks for. I had this couple. Celebrity couple, and simply because she was a celebrity, she refused to go. She said, everybody knows me and I will not. And finally she left the country. She went outside the country to get tested, simply because of the stigma attached. And forget this, and no matter how much I assured her, and then I spoke to a gynecologist, and the gynecologist said, we don't even have to give her name on the report, I can put another name and all of that, I can send somebody home. And no, she refused to, because her primary fear was that the gynecologist herself would judge her. So so much depends on y'all, the kind of attitude y'all have when clients come to y'all for STI screening. So I just want to drop it here. Yeah. So the shame, fear of judgment is is very true and very real, and not only from their partner, they don't want their partner to know, but they are also scared of the doctor that they have to visit, and then of course society comes last. So please remember this, that there are huge psychological barriers towards clients coming in for STI screening. So consensual non-monogamy, yeah, that I spoke about. Yeah, so now in my practice, this is what I wanted to point out to you all. I find that I have some clients who unnecessarily also every 4 months will go for testing. They have just come up with a plan where every 4 months I will go and get myself tested. So this we call over testing. And we also have, as I said, the other kind who, even though there is ample reason for them to go, will not go. So we have both sets, and I have seen both kinds of clients, yes. So one sentence I use with all of them is, hey, I ask all my clients, if there is a cheating in the relationship, it's non-consensual, which we call cheating, of course. If there is cheating in the relationship, I say it is imperative for me that I get a clearance from your doctor that you all don't have any STIs and STDs. And then I say, please come back to me only after you've gotten the clear sign from your doctors. So when I say that, then they know they can't come back. They have to get this done. And then I don't see them for many weeks. And I know it is because they are reluctant to go. That's fine. But eventually they do go and they do come back. Yeah. So just make it, normalize it, and give it a universal framework by saying, hey, I ask all my patients to do this. So could you please get an STI screening done? Helps. Okay. This is another issue in couples counseling. You will find this comes up. Women who are in perimenopause, menopause, and postmenopause. All of us prepare a girl for menarche, but we never prepare a woman for menopause. So women have a whole lot of myths, a whole lot of fears that comes up during this menopause, pre and post, and it can impact the dynamics in a relationship. So it's important for you to identify what some of the triggers are, and if you don't have the time or you're not inclined to help them deal with their very psychological fears and emotional distress, please direct them to a therapist or somebody who is qualified to deal with this bit. Then, of course, postnatal, we also find that sexual health gets impacted between a couple post-delivery. So this is something, again, you might have the couple coming in wanting to seek your help because there is some kind of sexual avoidance happening between them. So factor postnatal period besides menopause. Another one is infertility. Infertility can also be devastating for the couple, and it can impact the sexual health of the couple. Yes. So you might find that you also have to deal with this bit. As I said before, I'm saying it yet again, one understands that you don't have the time to spend to deal with your emotional distress. Please send them to a qualified psychologist or a therapist to deal with all of this. You might also see a couple in your clinic who one partner will control contraception, where either the man insists that the woman has a baby or gets pregnant, or you might have the woman being on the pill without telling the husband, or you might even have what we call stealthing, where you have a man who will tell his wife, yeah, let's not have a baby, but then he will either make a hole in his condom, or just before he has an orgasm, before he ejaculates, he will take his condom off and she might not even be aware. So we have so many things that happen, right? So this is something also you might see as a presenting issue with your patient and significant other that they are in a relationship with. So reproductive and hormonal health can also impact the dynamics between a couple. Again, I'm stuck. So escape. Again, I have to press escape.
Ma'am, this is press the space bar.
I just did.
Then downward arrow key.
I'm sorry, what key?
Downward arrow key. Downward arrow.
Okay, I did. No.
Then just press escape.
Okay. Halama.
Just stop sharing and share again once.
Okay. Is this okay?
Yes, madam.
Yes, ma'am.
Yeah. Okay. So let's meet in. The next bit is trauma consent. Okay. Now I'm going to run through because of time the trauma consent, and I
No,
mentioned
madam,
this.
it's okay. Don't hurry up. Just
You're
yeah,
okay because of the
yeah,
time.
it's fine, madam. We have time, no issue.
Okay, so the next bit is trauma. As I told you about, you are the front line. So if you see a couple and you see signs of trauma, then it's important for you to also check in. The first thing, of course, is sexual abuse. While 1 in 4 women have experienced sexual abuse, 1 in 6 men have also experienced sexual abuse. Now, do not believe that women or men are in sexually have been sexually abused before marriage, in childhood. Yeah, all of that is there, but also in marriage there can be sexual abuse. So please, if you have an adult client, patient, do not assume that they have experience. I mean, don't belittle or don't think as insignificant their sexual abuse in childhood. Also ask them whether there has been any sexual abuse in adulthood and whether there is any sexual abuse in the marriage itself, all of which you need to check, because again it can impact the dynamics between the couple. Okay, so trauma-informed care so what is in your consultation, how do you deal with trauma-informed care? The 5 key words are: if you sense any trauma in your patient, the first thing you have to do is hold the space for them, which means you have to make them feel safe. If they don't feel safe, they are not going to open up. And please remember, they have already been traumatized. And if you don't hold space for them safely, it is not going to allow for them to open up. The second is they must know that they can trust you. And by trust, it means it stays with you. And by trust, it means you will guide them as to what they must next do. And then, of course, choice, collaboration, and empowerment, all of which. For me, the 2 most keywords are: as a doctor, you need to hold space for them safely and allow for them to believe that you can be trusted. So, of course, how some of the signs that you are likely to see with your patients who are being traumatized in their relationship could be that there is somatization, or they don't want to go in for a physical examination, they don't want an internal examination, they don't want to do any smear test, or they don't, or the moment you go towards them, they kind of take a step back. You might just see the body going into shock mode. All of these little things you need to catch. You cannot ignore. Do not allow it to just pass. It needs to register when you are examining them. Another thing, now again, this in therapy I have seen, and this is so I thought I should make you all aware about it. We also find that some survivors seek non-traditional arrangements as a way to manage intimacy. So, which means you could, so for instance, I'm just going hypothetical here. If you have a patient who says that, I'm not carrying my husband's child, I have been impregnated by another man, you need to not pathologize the situation. You need to check in with her whether there is any trauma, because perhaps the husband is traumatized, or the husband cannot, he has an ED issue or whatever, but because of what it will entail with society and family, they might seek a non-traditional way of ensuring that they have a baby. So it is important for you to, again, not be non-judgmental, hold the space, and make them believe that you can be trusted with this, piece of information. So, this is just one example I'm giving you, yes? Yeah. So one sentence I have given you here, that could allow for you, if you sense that there is a little reluctance on the part of your patient when you're going to examine them, then maybe you can ask the sentence, is there anything about today's examination you think I should know so that I make it easier for you? Just one kind of sentence will tell your patient that, hey, my doc has picked up my discomfort. That's one. And the second thing is, my doctor is willing to talk about it by asking me if there is anything my doctor can do for me to make it easier for me. Hey, you can tick every box then. You have held the space for your patient and you have allowed for your patient to trust you and that you are there for your patient. So please, all it takes is this. Is there anything I can do to make this easier for you? That's all. This I'm not going to go to except for the last one. Yeah. STIs we did, all of which we finished. The last one I want to talk about, domestic abuse. Now, sometimes you might find your patient has come in with a medical problem, but you might see on them a certain injuries or blood clot or scratch, cut, whatever. I want for you to speak about it. If you see it, don't ignore it. Pick up on it and ask, hey, how did this happen? Or, have you gotten help for this? Or something like that. Just talk about it, because sometimes I find, at least in my practice, my clients will deliberately reveal a physical abuse scar. And if I don't pick up earlier on in my career, I would not pick up on it because I would think, oh, let me not embarrass them by asking about it. But later on, I realized that they sometimes reveal it deliberately, waiting for me to ask so that they can then tell. So if you see any marks on their body which seem out of place, please ask. Now there are we have a lot of psychometric tests also to help with screening for domestic abuse. I'm one of them. One of them is really long, so I would encourage you to not even try it. Send them to send them for psychometric testing to a clinical psychologist. But something like something like a HARK, for instance, you can use. It is very easy. HARK has only 4 questions. The first question is, have you suffered any humiliation? So which means, hey, then there is emotional abuse. A comes for, are you afraid of your husband or are you afraid of your partner? That means there is fear. And then R stands for, have you been raped? Which means there is sexual abuse. And K is, have you been kicked? Which means is there physical abuse. So which means you have checked in for emotional, sexual, physical abuse, and also if your patient is afraid of the perpetrator. All it takes is 4 questions. So maybe the HARK is something all of you can use. As for DASH, please send them to a clinical psychologist. It's a very lengthy test. So this is an intervention that y'all can use if y'all see signs of trauma. Please, y'all are frontline. Please catch it. Please don't be embarrassed to ask. LGBTQI, as an affirmative therapist, I have to put a slide here. Very important for me. There is nothing extra I want to say. I've been speaking, every time I've been speaking about couples, I have been saying same sex or opposite sex, but I thought I will drop a slide here for them. Because please remember this, that they have worse health outcomes than heterosexual couples. So same-sex couples, you really need to pay more attention. Besides paying more attention, you also need to make your clinic very, very affirmative, in the sense that simple things like even the form, the first intake form at the desk that they have to fill in, please see that your language suits the LGBTQI community. It cannot be sex, male, female only. You have to give others, for instance. Yeah. What is your husband's name? No. What is your spouse's name? What is your partner's name? What is your significant other's name? See that you devise a language in such a way that makes the anyone from the LGBTQ community feel safe. That's all I'm going to say with this slide. Yeah, sometimes we are asked as therapists that, hey, the CBT model you use, or in sex therapy when you use CBT, is it different for same sex and different for opposite sex couples? No, it's the same framework. Yes, it's just that we change the content, which means instead of same opposite sex, we use same sex couples, but otherwise the framework is the same. Okay, this is to end. I'm going to say a few takeaways for you. One is, of course, you must please refer your patients if you think this is beyond your scope, either because you don't know enough or because you don't have the time or you don't want to handle something like this. I don't want to open the Pandora's box. Then please refer them to a sex therapist or a CBT practitioner. But it's very important, besides you referring them to someone, you also tell them that this is something you do for all your patients and you're just not picking on them. Then they're going to think that, hey, there's something wrong with me, I need help. You normalize it by telling them, hey, this is something I offer all my patients. If you think you would want to be speaking to a therapist, then please contact these, give them options and choices. Why I say options and choices is because to find a therapist that suits you it's not easy. One is the language barrier. Not all therapists speak the language of your patient. Second, not all your patients can afford all the therapists. Third thing is perhaps not in the same city as your patient. So there are so many factors. So when you give a reference to your patient, please give them options. Yes, and please give them contact numbers. Don't just tell them, please go to a therapist. No, that's not a reference. A reference is when you give them options, yeah? Okay, red flags. I want to say this. One red flag is if you think your patient is suicidal, has suicide ideation, or there are signs of suicidality, then please never hesitate to immediately refer them to a therapist or a psychiatrist. That's one I want to pick up. The second one I want to pick up is if it is an adolescent, a child under the age of 16 or 18, if you see that there is signs of trauma or they are in a relationship, a sexual relationship with a much older person, you need to act on it. And of course, the last one is FGM. Yes? All of these are non-negotiables, and that's why I put them there. So what are the takeaways? The first takeaway, of course, is to ask the question. You have to ask them about their relationship dynamics. It is very important. Until and unless you ask them, they are not going to tell you. Trust me on this. With over 10,000 hours of therapy, I'll tell you this. If you don't ask, they will not tell. So please ask, and you will be surprised how every one of them will answer. The second one is please normalize and validate, no matter how shocked you are by what they reveal about their relationship. Keep a poker face and normalize it so that it doesn't make them feel shame. So some sentences you can use is, what you're describing to me is really common, but there are people who specialize in helping such situations. Would you want for me to give you some references? Or, this is something I recommend for anyone in your situation. Why don't you seek a therapist? Or you can say, I know this is really heavy and weighing on you. Would you want to meet someone whom you can talk to about it? That's another way. Or what you've described, it matters. I'm not going to invalidate it. I understand how significant it is to you, but you don't need to live with it. Maybe you need to get help. Do you want some contact numbers from me of people who could be able to help you? Just some examples I gave. Yeah, and this I mentioned before. Simply telling your patient to get professional help will not do. You must have a specific name, contact number, and I suggest you have many because it is for them to decide and for them to choose. If you give just one, they will feel compelled to go to just that person. So please don't make that mistake. Give them many numbers and email IDs and ask them to reach out and decide for themselves who they want to go to, but tell them go to someone they must. That's up to you. That's it. So I know I spoke really fast, and I tried to cover many aspects that tend to impact the relationship dynamics between a couple, and all of which I thought you should be aware of. Not that I'm expecting for any of you to do therapy with them, but because you see them, you can offer them hope. You can be non-judgmental, and then you must then refer them to the person who can help them. Just simply be non-judgmental. That is the most important thing. Second, be curious about your patients and want to learn more about them, and do what it takes to build a rapport, to connect. Remember what I said, to hold space for them, make them feel safe, and that make them believe that you can be trusted. That's all that is expected of you. Yep, I'm done. Now you need to help me. What do I need to do? I need to press escape again?
Stop sharing, madam.
Stop sharing. Ah.
That was a fabulous session, ma'am. And there are certain
you.
questions in the chat box if you can answer them.
Now, how will I read them? Is someone going to
Yeah,
read them?
I'll tell you.
Okay.
Yes, ma'am. How should doctors counsel experiencing mismatched libido? That is the first one.
Yeah, so one, you don't need to counsel them. Please send them to us, therapists. Okay? And I'll be honest here, those are the most difficult cases for us as sex therapists, when there's a mismatch in libido. It is very difficult for us. We just keep improvising as we go with them. How do you force someone to get turned on? Or how do you force someone to have sex with the other person if they don't want to? So one question I tend to ask when I have a one-on-one with them is, do you have this low libido only with this particular person or in general? Because that gives me a little bit of I get a foot in there to know a little bit more, and then I can move down that path. But they are very difficult. So I suggest you all don't even try to counsel them, simply refer them outside, outsource it.
Yes, but madam, how do you manage? Just give us a few outline. What are the ways to, what do you do in such cases?
So as I told you, this is the first question I will ask, but on a one-on-one, not when they come in for the joint session and they say that there is a mismatch in our libido level. When I have a one-on-one, I ask them that, hey, is this something you experience only with your husband or only with your wife? Some of them are honest and they say, no, it's always. Okay, so that's good. Some of them are honest and they say, no, only with my spouse. I find that I get turned on by others and I want to have sex with others. And then we take that part. Then when we come to a position where one person for sure doesn't want to have sex in the marriage anymore, while the other person is sexually frustrated in the marriage, we then take out the next arsenal in our bag where we say, hey, can we talk about a consensual non-monogamous relationship? By choice, if they are willing to speak about it. From my experience, I would say maybe 4 on 10 have said, okay, this is something we can explore. So that, especially the person who has a very low libido and does not want to have sex with the spouse or anybody else also will say that, I know, I completely understand it's unfair to my partner. So I don't mind it. If you want to have a consensual non-monogamous relationship with another, I'm good with it. But I have also seen couples where, in spite of one person not wanting to have sex at all, and the other person being sexually frustrated, has not given permission to the spouse to be in a consensual non-monogamous relationship. And then I take out my third arsenal in such case. In that case, I say, then maybe in the best interest of everyone, we need to end the relationship, because sex is a very important component of a marriage, right? It's one of the 4 pillars that holds up the edifice of a marriage. So if you have decided that you don't want to have sex anymore, I completely respect your decision, but I also need to respect the need, the sexual need of my other client. So maybe then we needed to talk about ending the marriage. Then we have a discussion. Everything is a discussion because you see, unless I speak about it or unless I drop it there, they're not going to speak about it. But that doesn't mean they're not thinking about it. When I voice it and I drop it, then they are forced to speak about it in the session. And then they decide what they must do. So these are some of the ways and some of the interventions we use, Neeraj. I hope that answered your question.
But Sunita madam, isn't that like giving to them option about the non-monogamous relationship or consensual non-monogamous relationship or the separation? Is there any other way we can just put for first?
I'm a therapist. I'm non-judgmental, and I'm open to anything. I can only inform my clients about options and choices they have. It is for them to deliberate, for them to discuss, and for them to come to a mutual understanding.
So if they are willing to work, then what will be the best option? Cognitive
How will
behavioral
they, how will
therapy
they
or
work if one person simply doesn't want to have sex? How is it going to work? We try all of this. Like for instance, when a real case would be when the woman was sexually frustrated in the marriage and the man he was simply uninterested in having sex and he was convinced he was asexual. But this is after they had, I think, 2 children or so. Um, so then I said, okay, why don't y'all invest in sex toys? I said, if you don't want to have sex, if you don't want to experience an orgasm, if you don't want to have penetration, at least use your sex toys, the sex toys you have with your wife, so that she can have an orgasm. You can help her with it, either digital stimulation or using a sex toy. But he says, I don't even feel like doing that. And then she at some point said, it's so fake. I know he doesn't want to do it. He's not interested. He's being compelled to. And after you have said, he says, oh, even the therapist thinks I should pleasure you, but it's not because he wants to. And when there is no involvement, then it all sounds so very fake, right? Who wants that? Who wants somebody to pleasure them because they're being compelled to? Otherwise, the marriage is going to break up. No, that's not something we want. And as I told you, as therapists, we are open to anything. We simply don't. We like to. We hold the space for them, and we allow for them to talk about options and choices, all of it.
But madam, options are there as you suggested, but it's not easy for because of so many social factor, familial factor comes into the picture when such cases are there. So it's not easy for them also not to choose like that option.
The law also says if my conjugal rights are not met, I can end the marriage. You can't force somebody to have sex. You can't. That's something you can't do. That's why I told you this is one of the most difficult cases we see where there is a mismatch.
Because in our culture, particularly Indian culture, now marriage is seen between two families. It's not between two individual. In general, I'm talking about.
I completely hear you. I completely hear you. But for two people to stay together is a recipe for disaster because before you know it, they're going to have sex outside the marriage without consent.
Yeah.
And that's cheating. Eventually, that's what's going to happen.
Yeah. But it will save their family values and everything.
Hey, but you can't be living life for your family. You have to be living life for yourself, right? I hear you, Neeraj. I completely hear you. And that's why I told you that, these are the most difficult cases for us.
Yes.
We can counsel them. There can be a way. Like, I mean, it's not an absolute no libido kind of a thing because there are so many people who come where the husband says, my wife is unwilling and husband is also willing. We counsel them, then we realize there is something or the other. I mean, very recently a patient came to me. She came to me for recurrent UTI. She was showing to someone, then she came to me. I got the investigations done and everything. She had infection. Then all of a sudden, her husband banged into my OPD. He did not come initially, and he all of a sudden he came to me and said, "Madam, what is the reason for my wife not being interested in sex?" And I mean, like even I was taken aback. That man, he straight away came in and he said, This is because of her thyroid that she's been having for last 15 years. So and this was around 3 days back. So I told them, just let her get rid of this UTI, then you'll need some couple therapy because we were actually supposed to be having this webinar. So that's how. So these people they come very frequently, and they have children, and it's not easy for them just to, I mean, to be apart
No, no,
or
see, this is if, I gave you worst case scenario because we always get worst case scenarios. When you guys can't deal with them, you'll send them to us. So we always get the
so
worst case scenarios. Whatever y'all can fix, y'all fix. And then when y'all can't, you'll send them to us. So for us, we see the tough ones. But if a couple comes saying that, I want to have sex once a week, and the other person says, no, I want to have once a month, hey, that we can work on. That definitely we can work on. The tough bit is when one says categorically, I don't want to have sex. Then what do? So, Richa here, so you look at the bio bit, right? Remember my slide about now you also then now delve into what are some of the psychological factors and what are the social factors. That's something you should explore. Maybe talk to her alone and talk to him alone. You might get two versions, and it's always important to get both perspectives.
we have to look into the bio part, and for the psycho part, we need to send her to you. And social part, both of us can look into a little bit.
No, I'm sure
And there's a,
psychological too. You might see about how the mood of both of them are, whether there's any anxiety or whether there's a low mood or whether there's any distress. There are many things y'all can catch. Many things y'all can catch. It's just that, sometimes you'll don't focus on it because you're so focused on the bio bit. Yeah, you're hyper focused on that, right? Because you want to give the best possible care. And that's the only approach you'll take. Well, someone like me will look at everything else because that's how we are trained, right? To take a very holistic view. We always say that therapists are on the balcony. It's not that we know better or we're higher. No, no. It's simply because we are always looking at a larger picture. So for us, there are many things that go into making that picture, not merely the presenting issue.
Yeah,
it can
next
even
one.
be the presentation of the person. I saw that man with a lot of, he was chewing this part. That can be one of, and the lady was spick and span. So that can also be one of the reasons. There are
See,
so many little
awesome.
things which actually, I mean, it must be putting her off, of course, because,
Awesome. See, you observed. Now, this is something you
yeah,
have to ask her when she's alone with you.
yeah,
And
that's what I
you,
thought next time. So I was taking up tips from this webinar. What all
perfect.
can we,
You got a foot in there by asking her that, and you will be surprised by what she's going to reveal to you. And then that's what you take to him, and you tell him that, hey, you need to change some things about you, make yourself presentable, desirable, if you want for her to have more sex with you. Hey, that's a lot. You see, you made an observation there. Come on, you're good at it. You can do this.
well, thank you, ma'am. There's another question. I think we can
Help.
take that. What communications help engage avoidant attachment patients who tend to underreport symptoms and avoid follow-up?
I'm sorry, could you repeat it one more time to me? I got the last bit.
Yeah. What communications help engage avoidant attachment patients who tend to underreport symptoms and avoid follow-up? Patients who underreport, who don't tell anything, and how can we engage those people? And they avoid the follow-ups. How can we engage them? I mean, what kind of communication can we have with them?
Because many times patient will not open up in the first visit. They takes time. They are not that much confident to talk about the issue. So how to ensure that they will open up?
So here's what I'm going to ask you. Do you ask them specific questions? They don't open up, but do you ask specific questions?
I mean, if required for what she has come to us, then we do.
Yeah, but
But
remember
not
that.
every time. We cannot do that.
So if you see that they are avoidant, for instance, if you sense it, so you already sense that. So you tick a box. So which means, hey, I can't only focus on the bio bit. I also need then to explore the psychosocial bit because this patient of mine seems a little reluctant, a little avoidant. I need to help them feel comfortable. So, which means I need to build a rapport. Then I need to hold a space for them. I have to show them that I'm non judgmental. I have to show them that I can be trusted. So much will depend on you to facilitate for them to be able to open up. My client doesn't open up is not a good enough reason. The job is ours to make them open up. Like for instance, you can, no matter how qualified you are, no matter how experienced you are, yeah, and you might have 1 hour with your client. I mean, in our case, we have 1 hour, right, with our clients. If when my client enters the door, in that first 2 minutes, if I don't make an impression on my client, it doesn't matter what the rest of the 58 minutes is like. The job is mine. When my client walks into my room, it is my job to make them feel comfortable enough. And if I find that they are avoidant and they are reluctant, I have to do what it takes to make them open up. I cannot say that they don't open up. It's my job. I have to learn ways in which I can. The simple fact that they came once is a giveaway. They want help. But perhaps they don't know how to ask for help. And that's where we step in, right? You can make all the difference. I gave you all some questions on the slides. Start using them, mug it up, and then start using them.
Okay, Shama, you can take rest of the questions in the chat box.
So next question, ma'am. Adolescents for coercive texting or digital abuse during routine consultations.
I'm sorry, I didn't hear the first bit of your question at all. You were frozen.
How can clinicians sensitively screen adolescents for coercive sexting or digital abuse during routine consultations? If adolescents are doing this, how do they screen?
Now, you see, one for digital addiction, there are psychometric tests. So if you're a clinician, you need to send them to a clinical psychologist for a psychometric test. You cannot tell your client, I mean, if you're a therapist, you cannot tell your client, give me your phone, I want to check it. Or you can't tell the parents, hey, can you like peep into their phone and check what they're doing? No, it's not going to happen. So what we then do is we ask for them to visit a clinical psychologist, and there are certain psychometric tests available to check in for digital addiction. They do the test, and then we get some insight into it by what the scores come out, and then the clinical psychologist will interpret the test result, and armed with that, then it's again our job with the test, we speak to the adolescent about it. Hey, but you seem to tell me this, but the test seems to show me this. You want to help me with this one? And again, with an adolescent, so here's the thing with adolescents, because they are underage, there are some disclaimers I give parents and clients and the adolescent client. So some of the disclaimers we want very much for them to be aware even before therapy starts is this. I tell all my clients who are underage and their parents that if the child, the adolescent, is at risk of harming themselves or another person, I will break confidentiality. If the adolescent or the underage child is indulging in risky behavior, by risky behavior, it could be driving with under the influence of alcohol. It could be having sex without contraception. If under the age of 16, having sex itself is illegal, yes? Or if they are indulging in substances and alcohol or smoking, all of which I tell my adolescent client, underage client, is reason for me to break confidentiality. So because I put it all there in my informed consent form, and parents also know about it, parents by and large trust the therapist to get whatever is troubling the child out of the child. And they know that if there's something to worry there, that we will inform them. That's the assurance we give. So armed with psychometric tests and then building a rapport with an adolescent client is the only way we can get this out of them, right? Yeah.
Yes, ma'am.
But madam,
Okay,
you can't,
another-
madam, you can't send all the adolescent to the psychotherapist now. So which adolescent will need this test, psycho test?
I put a slide there about adolescents indulging in digital in
Okay.
technology, right? And so, if you see sign, I put some signs there also, some symptoms that they could be exhibiting. If you see that and you sense that, and usually an adolescent is not going to come to a medical doctor alone. Will usually come with a parent or a caregiver, right? To the therapist, they come alone. But I don't think they come alone to a medical doctor. So it would be nice for you to also check in with the parent as to what their habits are as far as gadgets go. You could get some information there, right? Yeah.
Okay. The next
But
question
many
is
times,
like,
madam, parents will be not knowing about it. So, as a clinician, what's your basic aim should be to guide the adolescent or to take the confidence of the parent also, because it's a tricky situation.
If they are underage and you believe they are sexting, yeah,
Hmm.
especially under the age of 16, and you believe they are sexting, you have to convince your young client that it is very important for their safety that you inform the parents. You have to first inform your client that you will have to speak to the parents, but you are in their corner. That's how we do it. We always tell the client, hey, but I'm in your corner. I'm here with you. I got your back, but we need to inform your parents and let's do this together. That's how we do it.
yes, ma'am. So the next question is interesting that they are in a love marriage, but they have come to have IVF, stating that they have had never had sex and are comfortable with that. And although they
She's frozen only for me or for everyone?
No, no, it is frozen,
Ma'am,
madam.
it's frozen.
hello,
Durga, you are muted.
There you're back. I'm sorry, I
yeah,
didn't question at all.
yeah,
Yeah,
yeah. Am I audible now?
yes,
Yes,
you
yes.
are.
Yeah, there was a couple who came to IVF.
Hmm,
They were in a love marriage. Still, they didn't had any sex,
hmm,
and they were comfortable about it.
hmm.
And this case was sent to a therapist. But the questioner want to know that is it a normal or abnormal
Uh,
in
the
a love
fact,
marriage?
the fact that they are not having sex, and the fact that they have gone for IVF without consummating the marriage.
And they have love marriage.
Okay. Now, so I'm going to break it up into three parts. One bit, it doesn't matter if they are in theirs is a love marriage or arranged marriage. It doesn't imply that because it's a love marriage, hey, we're going to have sex for sure. And arranged marriage, we might not have sex. No, that's the first bit. The second bit is going for IVF without consummating the marriage. I don't know what the legal policy is, y'all are the doctors, but I do know in some countries, if you haven't consummated the marriage, you cannot go for IVF. I don't know what the legal system in India is.
No,
Yeah.
it's not like that here.
Yeah. So if they have not consummated the marriage and they have gone to a doctor for IVF, if I was a doctor, the first thing I would do is ask why the marriage has not been consummated. And I would first ask for them to start having sex for pleasure before they even think of starting a family. But they somehow got past that and they got pregnant. That's fine. Lucky them, lucky dog. It's worked for them. It's okay to not. I'm glad. Hey, they are both in sync. Both don't want to have sex. That's a perfect situation. And let's not assume that because they don't want to have sex today, they're not going to want to have sex tomorrow. Who knows? Childbirth, all of that, life catches up. They might want to have sex with each other. It will change. It's constantly evolving, right? The sexual dynamics in a relationship.
Yes, ma'am.
Mm.
So, other one asked like why we say it's problematic porn watching if the couple have enjoyed orgasm with porn.
As I said in my slide, I've also said pornography is not evil. I don't come from the school of thought that believes pornography is evil, but we need to differentiate between pornography, normative use, and problematic use. And I did give an example. There are many couples who watch pornography together as a part of foreplay. That's fine. The problematic usage of pornography comes when there is addiction and when expectations build for partner sex based on what they have seen in pornography. That's when pornography becomes problematic. Pornography by itself is not evil. Please, the only thing I tell my clients is if you must watch pornography, please watch ethical pornography because the pornographic industry is evil. But if you watch ethical pornography, it means you're paying per view. And if you're paying per view, it implies that everybody involved in the filming of pornographic films is paid for. It's just another industry, right?
Yes, ma'am. So another question is like, do the male partner with decreasing libido just stop intimacy and cuddling? Is it mostly decrease male testosterone or related to mental disease?
Now, the medical bit I can't answer. Yeah. So how do I deal with? I can only tell you how I deal with. So if a couple comes in and the man says that I'm losing interest in sex and I don't mind physical intimacy, but penetrative sex and all of that, no, not my scene. Orgasm, I don't want to even think about. But I don't mind spooning or I don't mind cuddling or all of that. Then again, my first thing I say is I'd like very much for you to visit a urologist. I'd very much like for you to meet a sexologist. And could you get a checkup done? Because let's get that out of the way. I'm not a medical doctor, so I will have to send you to a medical doctor. Could you please go and run whatever test the doctor thinks is essential? And once the doctor says, hey, there's nothing there with your body, then you guys come back to me. But until you'll do that, I can't be dealing with this because there could be a medical problem and I'm not qualified is how I deal with it in therapy.
Okay. The next question is little bit connected to previous, like husband is had some hernial operation 2 year back or some fever, and he had some feeling of not to have sex because of that reason. But female is having more desire, but husband have fear that he did not satisfy the lady. So what will you do in that situation? Husband is fearing that he had some operation or fever, but he has the at the same time he have a fear that he is not satisfying his wife who have desire.
I'm going to say one thing here. Sex does not mean penetrative sex. Yeah. Sex even involves intimacy, physical intimacy. You can also have oral sex. You can also have a hand job, digital stimulation. There are so many ways in which a couple can have sex. And all sex does not mean must end in orgasm. So if he is concerned that his wife is perhaps getting an unfair deal, and he's concerned about that, but he for sure doesn't feel like having sex, he can do what it takes to pleasure her. How hard is that? That's not difficult, right?
Yes.
Yes.
Any other
So, Neetu,
question?
any more questions?
Ma'am, no more
Thank you so
questions.
much, ma'am. Yeah, thank you so much, ma'am.
Thank you. And
That's the
I'm
end
so
of the
sorry
session.
for all the glitches. My apologies.
It's perfect.
My
No issue.
apologies.
We really enjoy it.
Yeah.
Yes, some vote of thanks.
Yes, sir. So, as we come to the end of this insightful session on couple therapy in sexual health, under the series Sexual Health Ki Pathshala episode 5, it is my great privilege to propose a vote of thanks. First and foremost, I would like to express our sincere gratitude to our esteemed speaker, Ms. Sunita Menon, ma'am. for sharing her valuable knowledge, clinical experience, and thoughtful perspectives on couple therapy. Your guidance has helped us understand the importance of communication, empathy, and professional support in improving sexual health and relationships. Thanks to my co-moderator, Dr. Richa Paharia ma'am, for great moderation. And also, I would like to thank the leadership and the organizing team of SexMed Connect, especially our president, Dr. Neeraj Jadhav sir, vice president, Dr. Apurva Datta sir, secretary, that's me, and joint secretary, Dr. Naisargi ma'am, and for their continuous efforts in creating such a meaningful educational platforms for healthcare professionals. And a special thanks to our technology partner, Medisage, Neetu, for facilitating this webinar smoothly and enabling us to connect with participants from different places. And also, finally, my heartfelt appreciation goes to all the participants and attendees who joined us today and actively listened and made this session interactive and successful. Your enthusiasm and commitment to learning make initiatives like this truly worthwhile. And we hope today's discussion will help us all address sexual health concerns with greater sensitivity and confidence in our practice. So, thank you once again to everyone involved, and have a wonderful evening. Thank you.
Thank you so much for the opportunity. Thank you.
Thank you, Sama and Dr. Rita, and thank you, Sunita madam. It was really nice and really enjoyed your presentation.
Thank you. Thank you
Thank
very
you.
much.
Thank you so much, Sunita ma'am.
Thank you.
It's wonderful.
Thank you.
Thank
You're
you.
welcome. Bye. Good night.
Good night.
Bye bye.